Medications for opioid use disorders in correctional settings. Shifting the paradigm, creating a balanced correctional and rehabilitative approach. The Opioid Response Network is funded by SAMHSA to provide resources and technical assistance needed locally to address the opioid crisis. This video is part of a series to provide guidance on the implementation of medications for opioid use disorder in correctional facilities. Leading corrections and behavioral health experts present information on topics such as the use of medication, models of delivery, diversion, and linkages to care and community support. Ross MacDonald and Barry Weiner discuss staff buy-in.
Hello, thanks for having me. So I'm going to tell you a little bit about the work that we've been doing in New York City for many years. So this is the New York City jail system. Rikers Island is in the middle, and then there are historically three borough houses and one boat that floats off of the Bronx. Interestingly, the system is shrinking quickly, so I'm going to have to update this slide and start crossing off facilities. Actually, the one on the top right has closed within the last few months, and 2 of the 9 facilities will be closed by March on Rikers Island itself. So a time of a lot of change in criminal justice in the US, and a very appropriate time to be having this conversation about MOUD in these settings. So in New York City, we've had an opioid treatment program running in the jail since 1987. We are the nation's first by a long shot, and for over 30 years have been the nation's largest jail-based opioid treatment program. So I was going to joke that I'm going to tell you what it was like when we started that, but as you can guess, I wasn't around when that happened. Actually, it was many of the folks who pioneered the treatment of methadone itself in the 1970s and began to scale it up as a treatment for substance use populations in the community, first in New York City, who naturally brought it to the jail, understanding that at that time, in the midst of a heroin epidemic, that many of the patients who needed that treatment would be in the jail at some point. So for my role as Chief Medical Officer, what I did was inherit a program. And that's very different from starting a program. But I think what I hope to give you is a little sense of where you can get to, which is really a place where this is a non-issue between health staff, between security staff. This is just part of what we do and what we've always done. And I think it serves as an example to assuage some of the fears that people have that this is going to change everything about the way we do business, that this is going to open some kind of Pandora's box. Really, the administration of correctional facilities is among the most complex work that humans can do. They're incredibly complex institutions, and when you superimpose healthcare delivery systems on top of that, it's really challenging work, as many people in this room know. And to incorporate this is not a challenge that's going to be insurmountable. I'm going to talk about some of what I would call the fundamentals of buy-in, and the way that I make the argument. I'm a doctor, and my staff are all health staff. So in New York City, there's a division of labor between the New York City Health and Hospitals, which is the public hospital system, and the New York City Department of Correction. So we are in the jails tasked with providing medical, mental health care, social work, and reentry services as an independent health authority. So we're actually separate. I report to the president of the public hospital system, not to anyone in DOC. So we have a strong working relationship and a partnership. But my staff are healthcare staff. So a lot of this will be the way that I talk to my healthcare staff about this work. And I think that, what I aim to do is give you some information which you've probably heard, but I think it needs to be repeated. We need to continue to push our communication strategies to try to get across why this is the right thing to do. And I think I put that into 4 large buckets of how I try to get it across. The first is that I think we have to admit what the criminal justice system historically has done, particularly with regard to OUD, just empirically doesn't work. And we'll talk about that a little bit. Second is that these medications, particularly the opioid agonists, have been shown to save lives, and that's an important goal of our work. The second and third are really about the facility itself. So diversion, in my experience, is one of the biggest concerns that gets raised. And from a system that's been doing this for over 30 years, I'm here to say that it is a problem, it's a legitimate problem, it happens, but it's something that can be managed. It's not a reason not to do this work. And the last is that I think there's an evidence base, and it's a growing evidence base as more and more systems implement these programs, that it actually makes everyone's life better. It makes the lives of our patients better, and that makes things easier for healthcare staff and for security staff. So what are some of the reasons that I say that our current practice is often ineffective? And when I say current practice, I mean not just what happens in jail, but what we do as a society to use criminal justice to respond to addiction as a problem. And the first reason, as I hope to explain, is that the premise, in some sense, is incompatible with addiction itself. And then the second is that we have a lot of evidence that it's not working. One piece is the high rates of relapse after incarceration. One piece is some work we've done around looking at the people who come back to jail the most frequently. And one piece of evidence is the clear indication that jailing in particular increases people's risk of overdose death. So this is a definition of addiction, which you may have heard. This comes from NIDA, and I think this is how I try to get it across to my staff, that addiction is a chronic relapsing brain disease that's characterized by compulsive drug seeking and use despite harmful consequences. And it's a really complicated disease, and I think part of the reason that I make the argument that the criminal justice response has not been particularly effective as a societal response to addiction is that it only addresses small parts of the puzzle. Addiction is complex in any individual, and it really starts in childhood. It's influenced by biology and genetics. It's influenced by the environment, particularly the early environment. And the biggest risk factors are things like poverty and trauma, which we know affect our patient populations. Along the way, those individuals with those risk factors are exposed to drugs, and that part is important. And really, this is where the criminal justice system can have an impact, impacting availability and cost, which do have impacts on the way that people are exposed to these drugs, and at a population level may reduce the overall risk of addiction or the prevalence of addiction in society. But that's not really helpful for the patients that we find who come to us already with addiction. They've certainly been exposed to the drugs, and there's another process that happens to them, which is that the drugs start to interact with their brains and over time change their brains, leading to the process of addiction. So the criminal justice system's sort of lever to act on this complex arrangement is fairly limited. Another problem is that people with addiction tend to come into contact with the criminal justice system. So particularly for opioids, we see a common pathway where initially using a drug like heroin will make a state of euphoria. And initially when people start using it, they come back relatively to their baseline self when they're done. But there's a natural process that ties into the way that the drug itself changes the brain, where they become more tolerant to the medication or to the drug. And over time, continuing to use results in diminishing returns. And so they find themselves having to use more and more, and they find that they're not over time returning to their baseline, but they're returning to a state that is actually the opposite of what they were trying to achieve. They're returning to a state of what we call dysphoria. So all of the things that feel great about using the drug now start to feel very bad when you don't have access to the drug. And eventually this process leads to cycles of withdrawal, and many patients with heroin addiction or opioid addiction find themselves in a cycle where they have to use more and more just to feel normal. And it can actually be very difficult to achieve euphoria. And the doses that are required to achieve euphoria become very high. And all of this leads to an increasing cost of addiction to the patient. And we know that a lot of what we call acquisitive criminal activity is related to this. So if you're going to feel very sick, if you don't get access to this, then you are, as a human, motivated to try to get access. And that means you have to make money, and that often leads to criminal activity. Another piece of evidence that we have that what we do doesn't always work is when we look at people who come to jail most frequently. So in New York City, at a time before a lot of the criminal justice reform that I mentioned, we looked at the people who returned to jail the most. And we found a group of 800 people who, over a 6-year period, accounted for over 16,000 incarcerations. And that means that each of those people in those 6 years were coming back more than 20 times to jail. And when we drill down on what's going on with this population, I think, the popular narrative is that this is a mental health problem. But really what we found in the most frequently incarcerated patients was rates of significant substance use that were in excess of 97%. And really, I think in some ways this represents a failure, not just on the part of these patients, but on the part of us as a society to think that continuing to do the same thing for these patients is going to change anything about the cycle that they're caught in. And so, again, I come back to this definition of addiction, which is compulsive drug seeking and use despite harmful consequences. And really, the criminal justice response historically is to pile on another harmful consequence. And simply, it doesn't work. There are things that we know help people with addiction. There are things related to treatment and pharmacotherapy. The medications are a critical part of that. But a lot of the things that help people don't have much to do with treatment at all. They have to do with their life. So we know that a job that brings you money to feed yourself, to feed your family, that gives you meaning in your life is incredibly important for protecting people and supporting recovery. We know that housing is a critical element, a feeling of personal safety, mental health care, and in particular the processing of trauma and avoiding re-exposure to trauma, and things like self-esteem. And again, these are all elements of recovery that the criminal justice response tends to destabilize more so than it historically has been able to help. So incarceration and addiction really doubles down on the harmful consequences for a condition that we know does not respond to harmful consequences. And it can destabilize those protective supports, which may have already been threatened by addiction itself. And then at the end of all that, the treatment that is most frequently encountered when someone arrives in a criminal justice facility is one that we clearly know not to be effective. So we have a huge body of literature for opioid use disorder that shows that detoxification alone doesn't work. So in this study, 83% of people had relapsed at 30 days. But if you carry that out further, it reaches nearly 100%. And just as an aside, there are things that work better. So a similar graph where we show people relapsing over time. The line at the top are people who are offered buprenorphine maintenance, and it really changes the curve. It doesn't cure the disease, which is a complex disease. It's not a magic bullet, but it makes a huge difference. And it changes an intervention that we almost could say we know will not work into one that might work for many people. So this is what we usually find at the end of this criminal justice response that really is not responsive to the problem of addiction itself. And the end result of that is not surprising. We know that sending people to jail, particularly people dependent on opioids, increases their risk of death. We know this from prison data, we know this from jail data, and we've seen it in data from across the world. And most of this increased risk of death is driven by overdose. These are data from New York City. So the polka dot line is the criminal justice population, and it's compared to all of New York City in the black and people in the poorest neighborhoods in the white. And you see that the risk for our patients is highest for all these causes of death, drug-related, homicide, and suicide, but it's really drug-related that stands out. And we think that this is largely an interaction with incarceration itself. It's also very predictable in time, so the time immediately following release is the most dangerous, but the risk remains high for this group. And we know what works for this. Opioid agonist therapy has been shown to reduce this risk by about 75% across multiple studies. This is a study from Australia that shows the rate of death post-release for 3 populations, one that had access to methadone, actually 2 populations that had access to methadone, either partial or complete access. Those are the blue and green lines at the bottom. And one group that didn't have access to methadone, which died at the highest rate after release. This is similar data from England, showing both all-cause mortality and opioid-related mortality. The group that has access to methadone simply dies less. In general, we have international data to present here, and this is because from these data in 2008, there were extremely few people on these medications in criminal justice settings in the United States. So we had to look to places like Australia, which have a long history of using methadone in jails and prisons to get these data. This, as you know, is changing really rapidly, and thankful to our colleagues in Rhode Island for giving us the first glimmer of data from the United States to show what we basically know, which is that these medicines work to prevent people from dying. So very grateful to many colleagues in this room for these data, demonstrating a reduction in the proportion of statewide OD, which was among the recently incarcerated. So one strategy I would recommend for achieving buy-in is to do exactly this, to look at data in your jurisdiction. So most localities have medical examiners who do autopsies, and usually overdose is a condition that results in autopsy. And they may be good partners to match the people leaving jails or prisons with death data. And we know what you'll find. You'll find overdoses concentrated in the recently released. But oftentimes to see that data locally really means something different than to see data presented from Australia or another place in the country or in the world. Another thing to do would be to look at the frequently incarcerated, as we have, and see, what are we doing as a system over and over, expecting a different result for these patients. And I think if you do a quick chart review of those people that you know the best, you'll find that the rates of substance use disorders are extremely high. This slide got a little cozy. So I just want to point out that we've done this in New York City, and despite having the nation's oldest and largest jail-based opioid treatment program, we found that still among our patients, opioid overdose was the leading cause of death. And when we really drilled down into those patients, in the pie chart that's peeking out from behind the other pie chart, we found it was the patients who were not treated with methadone or buprenorphine who were dying. So even in a program like ours, there's opportunity to improve, and there are barriers to getting people the treatment that they need. At that time, the biggest barrier was what we called eligibility. And so the state prison system at that time didn't accept patients on methadone or buprenorphine. And so historically, since 1987, there had been charge-based exclusion criteria for participation in our methadone program. And these data showing still that people are dying after release, and it's the people that we can't treat with methadone, prompted us to really work hard, both to collaborate with the state to try to change that policy, and to try to think about creative ways that we could get around it using data. I'm happy to say that in late 2017, we were able to throw those eligibility criteria out the window, and we actually tripled the size of our patient population on methadone maintenance. I don't have the data to present here because they're too new, but we also have demonstrated that that saved lives. So just that change, increasing the size of our methadone program, probably resulted in an additional 14 post-release deaths averted just in a 9-month period that we looked at. So the treatment is powerful and the risk is really high. So this is something that works. And if you look closely at the data in your jurisdiction, you'll see these same relationships. I'm going to talk a little bit about diversion. Diversion is the most oft-cited concern when it comes to naysayers, and it's a concern that should be legitimized. It's a real issue, but it's an issue that can be managed. And really the key way to manage it is an orderly, collaborative process between health staff and security staff to do good DOT. And if you do that, you will find certain patients who try to divert the medication, and you need to have clear policies in place for those patients. You need to be upfront with them before they start the treatment about what's going to happen if that occurs. But all these systems make it a very manageable problem. We have what we call a zero tolerance policy, which we describe to the patients and they agree to before they start treatment. And we've really gotten to a place in our system where diversion is not an issue that comes up very often. I think there are other things to think about when you think about the safety of the facility. The meds that could be diverted, particularly with buprenorphine, which is slightly easier to divert than methadone, but I would argue is much safer when it is diverted to have as a risk factor in the facility. Other things that people might have access to in the facility include things like fentanyl, include things like K2. And buprenorphine is very, in and of itself, is very low risk of overdose if it's used even illicitly in that manner. I would also say the formulation matters. So using, trying different formulations, working with your health staff to see what works best. Many systems have moved towards crushed buprenorphine, which is probably the easiest and cheapest way to do bup. I also point out that these are essential medications. So one of the things you'll hear is that Suboxone gets smuggled into the facility. And that's a rationale for why we shouldn't be providing it to people, because clearly if they're smuggling it in, it's a drug of abuse. Well, we know that in the community, most people who use buprenorphine, even when it's acquired from an illicit source, use it for therapeutic reasons. They use it to manage withdrawal. These medications have been on the WHO list of essential medications since 2005. So I often ask, our staff, what do they think would happen if we didn't offer HIV meds, or if we didn't offer diabetes meds? Would there be some system to smuggle those things into the facility? I think there would. I also point out that Suboxone is one of the only opioids, or the only opioid available that comes in a film form. And so it's a slightly an unfortunate accident that it happens to be produced in this highly smuggleable form. And that's one of the reasons why we don't use Suboxone. We use either crushed generic buprenorphine or one of the other formulations, the ultra rapid dissolving tablets. And that does two things. One, it allows us to get away from that stigmatization that's been associated with Suboxone. We do use buprenorphine, but we don't use Suboxone. And the other thing it does is it allows to separate diverted medications around the facility from smuggled meds. And most of the meds that you'll find are indeed smuggled into the facility. Diversion happens, but it's not really changing the dynamic of the market for drugs inside the facility. Another question is, is there drug use in facilities that don't have such a program? Most facilities do large-scale screening programs, urine drug screening programs. So I would just ask, do people come back positive? Sometimes they do. And those drugs are very dangerous. They're fentanyl, they're K2, things you can't even see sometimes on those urine drug screens. And so, to be honest with ourselves, that there is no truly drug-free facility to begin with. So the bottom line for diversion is it's not a valid reason to deny a life-saving medicine. And it's an important concern that we need to work through, but it can be done. And the last thing I'll say is a little bit theoretical for me, again, because we've been doing this since 1987. But I think that there's evidence to show that this makes a better jail. This is a study from, again, from Australia, where most of the prisons in Australia, so even for long-term stay, offer methadone. And this study looked at the impact on mortality of methadone access in prisons over time. And it actually showed a reduction in death in the facility. So we talk a lot about post-release death, and that's very important, but this is evidence of reduced death in the facility. And this was really driven by a marked reduction in what the authors called unnatural death, an 87% reduction. And unnatural death includes things like suicide, overdose, homicide, and accidental death. Having spent many years being invested in the way these facilities work, these are things that make us lose sleep at night. These are things that we worry about. These are things that we cringe at. But also behind all these things are how people are feeling, how people are doing, how much violence is behind each case of homicide. So these are indications that when you treat people appropriately with the medicines that we know work, they're going to feel better, they're going to behave better, they're going to die less. And I think in the end, it's going to make all of our lives easier. I think, the last thing I'll say, again, from this easy position of having inherited rather than initiated a program, is that buy-in only takes you so far. And really what's changing is the landscape where this is not optional anymore. It's hard to convince staff that they should change what they need to do, but the truth is that we're at a point where they are going to change what they need to do. And the good news is that we can convince them that that's the right thing to do. And that changes the calculus. Not everyone's going to be completely on board, but some people will believe in this. And since we have to do it either way, those are the people you want to lean on to make these programs work. Thanks.
Buy-in. What a simple word. It's only 5 letters, 2 syllables. But I propose to you this morning that it's probably the most important word you're going to hear during this entire symposium if you want to have an effective MAT program. Good morning. My name is Barry Weiner. I'm the Assistant Director of Rehabilitative Services here in Rhode Island at the Department of Corrections. I've had the privilege of having this job for 5.5 years, a short time. Before that, I worked for 31 years in federal community corrections. I started as a probation officer in New York. In fact, in social work school, my first field placement was at Rikers Island Women's Jail, so that's when I got my feet wet about 4 decades ago. I then did about 12 years as a supervisor in the Middle District of Florida, the Tampa area, and then the last 14 years of my career, I was the chief federal probation, pretrial, and parole officer here in Rhode Island. So what happened? Why did I leave? They said I was too old to do the job. You know, in the federal system, at age 57 in federal law enforcement, which probation is considered, you got to go, you got to retire. Whether you like it or not. So I'm too old, and that's how the state got me. I left there on a Friday, and A.T. Wall, our former director, some of you may know him. He was the longest standing corrections director in the country, served for 18 years, hired me. And here I am. So what do I do as the assistant director? Well, I oversee the programs for rehabilitative services in the institution and also in community corrections. What I tell friends that I do is I'm an air traffic controller. Basically, we have all of these programs, all of these planes flying in the air with folks, good folks running them, and my job is just to make sure they stay flying. And every once in a while, a plane comes down. And it's my job to work with our folks to clean it up and get the airplane back in the air. I'm going to boast about one thing about myself, one thing that I'm really, really proud of. And the thing that I'm most proud of in my career is that I convinced Jennifer Clark to apply for the position of medical director. She was reluctant at first, but she accepted, and our then director, A.T. Wall, was smart enough to grab her up in a second. And the second smartest thing was to allow Dr. Clark to put together a team. And you've heard from many members of that team yesterday, from one of our wardens to a deputy warden to a lieutenant to our friends at Kodak and to some of the people behind the scenes like Loran Howard and Rose Martin. And together, that team makes it successful. So if you look at my first slide, it's all about people. That's hint number 1 to get buy-in. Get the right people involved, make them champions, and let them help you push the program along. So you've heard some really nice things from Dr. MacDonald about MAT and why it works and how it works. And you've heard some many other presentations the last day and a half of a similar sort. And you've learned a lot, I think, about this program and what it is and why it should work. That's great. Now, tomorrow, most of you are going to go home and back to your agencies, and people are going to say, so, what do you think? What did you learn? And wouldn't it be wonderful, I mean, absolutely amazing, if when you went back home and you presented the information that you learned to your team and all the shareholders about MAT, they immediately jumped on board. They said, wow, this is great. You know, you got wonderful, wonderful information. You got great insight, intelligence. This is great. We're going to do this, and we're going to make it successful. Well, I hate to be the bearer of bad news, but don't expect that, because it's not going to happen. The chances are very little to none. Unless you listen carefully to the information I'm going to present this morning and the things that you're going to hear in the workshops this afternoon. So if you were planning on taking a nap, I don't see anybody here taking a nap, but if you were planning on it, forget it, because there's some really important information that I have for you. So in the real world, and even more so in the corrections world, right? And we all know the real world and the corrections world, that's two different worlds. You must expect folks to put up obstacles to new initiatives, right? Because that's just how we are in corrections. We don't accept new things. And these obstacles can really easily derail a project. It's not the exception, it's the norm. It happens every day. So expect it and be prepared for it. This is especially true for initiatives that seem totally counterintuitive for large groups of employees. And you think this program sounds counterintuitive? Of course it does. You're going to hear things like, we heard, wait a second, we've been working for decades to keep drugs out of our facilities. Now we're going to bring them in? I can't think of a crazier, more illogical and stupid idea, right? And those of you who work in facilities, you know you're going to hear that. It doesn't matter that the ideas and information that you come home with and digested at this symposium are needed, they're innovative, they're logical, and all those good words that go along with it. Your proposal is going to be shot down by many if you don't handle it skillfully and tactfully, and it'll die a slow death. So why is this? How can you prevent it? What could you do? I would guess that most of you in this room were selected to come here because you're pretty good at coming up with ideas, looking at problems, and coming up with solutions, and that's important. But what's even more important is to be skilled in the knowledge and instruction on how to implement those good ideas. What does research tell us about organizational change? Did you know that 70% of all organizational change fails? Why do you think that is? How can you ensure that the organizational change you're about to embark on doesn't become one of that 70%? Let me give you a quick example. We talked about coffee before. Doesn't that coffee look good? I suppose most of you in this room like coffee. So I'm going to give you a quick example of something that I observed at a previous job. It's not about MAT, but the principles, I think, are exactly the same. In this company that I worked, they had a break room with a coffee pot. And this coffee pot worked. Someone would buy the coffee every month. If you wanted a cup, you'd put 50 cents in the jar, and you would grab the cup of coffee, and you would drink it. Coffee wasn't really very good, but it was better than nothing. Until Jim and John had this great idea. They said, why don't we put in like this really high quality coffee maker? You know, the kind that like you put the grounds in and it grinds the grounds and it puts it right in the cup. I did some research, they said, and they found that for $1 a cup, they could get that kind of coffee, which would be like excellent, and the company wouldn't even charge for the coffee maker. Great idea, right? How could it go wrong? So what do? They send out an email to everyone in the office, and they tell them, we have this idea of this new machine. Is everybody in? What do you think? You think everybody was in? They got buy-in? It wasn't received well, because rare is the new proposal that doesn't receive opposition, and it got opposition. Sure enough, immediately after the email went out, someone responded with an attack. This is not an issue. The coffee is fine. And then came the email from Mary. Mary was the secretary that everybody loved, long-term employee who was in charge of the current coffee club. She writes, I buy the coffee from a good supplier, and I regularly clean out the coffee maker, which has pretty good coffee for as long as I can remember. This is the first complaint I have ever received about the coffee. If you want perfect coffee, just go down the block to Starbucks. Personally, I prefer ours, and besides, most of us are swamped with work, so why are we writing emails about coffee? Let's move on. This email almost killed the plan. What had they done? They unintentionally insulted a terrific employee, and they now look like two self-centered, elitist complainers. Was this response predictable? Of course it was. Could it have been avoided? Of course it could have. It could have been avoided by seeking input from the stakeholders. Who were the stakeholders in this? They didn't think about that, especially Mary. They could have discussed the matter with Mary, gotten some buy-in from her, made her an ally. Maybe even she should have been the one to send out the email. So the situation was eventually rectified. They apologized to Mary. They told her they got her on board. She sent out the second email. Everybody joined and had great coffee ever after. Again, it has nothing to do with MAT, but the example, I think, is analogous to what happens when we do change in organizations, large and small, and what happens when we don't think about buy-in. So my point, buy-in is critical to making any significant organizational change. Unless you win support from people at all levels of the organization, and that's from your director all the way down to the newest recruit who just came on board last week, the project's not going to take hold, and it's not going to have the impact that you want. Most of the 70% of the failures that we talked about are because leaders simply didn't get enough buy-in, and they didn't get it early enough in the process. So, as you go home and either implement or modify or expand your MAT program, depending where you are in your state, make sure you consider the importance of getting buy-in as a top priority, just as important as all these medical things you've been hearing the last day and a half. So, how do you present your initiative without it being shot down? And how do you build sufficiently strong support for it so that successful actions follow? First, you have to know your stakeholders and which of 4 categories they'll all fall into. Has anyone ever seen this bell chart before? Can you read it in the back? No, so let me help you with it. Whenever there's organizational change, people are going to fall into one of 4 categories. All the way on the left are your innovators and early adopters. These are your allies. These are like the great people. You know, you present MAT, the idea, they love it, they think it's great, they're bought in. When can we start? How can I help you? Just wonderful, wonderful people, make you feel very good about yourself. But, like with any good thing come bad things, there's the other side of the spectrum, And those are the resistors or the laggards. And those are the people who hate the idea. They think it's awful. They think it's stupid. They think it's a mistake. And there's very little that you can do to sway those people to change their mind. You can try to change their mind, but sometimes you just have to tolerate them. And one mistake that managers make, and I made this mistake when I was a new manager, because I wanted everybody to be happy with my programs. I wanted everybody to be on board. So I would spend a lot of time and attention on those resistors, and oftentimes without results. And I then realized that some of that was wasted time, which could have put toward the more important group, which is the middle group, which I call the fence sitters. The slide calls it early majority and later majority. Now that's, so on average with the change, about 16% of the people fall into the early folks, the excited people, the innovators. They're kind of like the people, you know how Apple puts out a new phone and there's people online like 24 or 48 hours before because they want to be the first one to have it? Those are those folks. About 16% on average, and then the resistors, laggards, are also about 16%. So between them, they make up about 32%. But the mass is in the middle at 68%. And this is the important group that you have to persuade and get on board. So they're fence sitters. They don't know. They're quite just not sure whether this is a good idea or not. But they're willing to listen. They're willing to pay attention. They're willing to engage in discussion and dialogue. And hopefully, with time, with some champions from the early group, from the innovators and early adopters. So again, if you're in charge of this, grab those innovators and early adopters, task them to be champions, and bring on board the fence sitters. And this will happen slowly, and the more that come on board, the more that are going to come on board. And when you have a majority of the folks on board, then your initiative is going to move forward. And it could happen through education, discussion, training, many of the things we talked about. Let me ask a question. Nobody's watching, so let's be honest. For the people in the room, I'm just going to ask you to raise your hand. When you first learned about MAT, think back, and for some of you it might have been at this symposium, for some of you it might have been years ago. How many of you were early adopters, innovators? You heard it and you knew this was like the best thing since chopped liver. Okay. Not too many. I'd say a very small percentage. How many of you were on the opposite end of the spectrum, resistors and laggards, like this is crazy, this is stupid, this will never work, this will be the biggest mistake we ever had? Be honest, nobody's looking. Okay, just a very, very few hands. And that's unusual because probably if you're the boss or your boss sent you here, you're probably someone not typical. How many kind of in the middle? Like, I don't know, I need to learn more. Okay, clearly that's the vast majority of people. And then I'm going to ask one more question and move on. How many of you, since you've been here at the symposium and since you first learned about MAT, have moved from where you were, either as a resistor or maybe a fence sitter, and now are someone that believes in this and has buy-in? Okay. Again, quite a few. So it is possible to move people along the continuum. Many of you have been there, and it's going to be your job when you go back home to bring the troops with you if you're going to be responsible and part of the team to get people to accept buy-in. So recruit your troops, the early adopters, get them to actively engage the fence sitters. By converting them, we'll move them forward. Look for informal leaders, and you'll know who they are, and bring them on board. And once converted, they'll bring others. Always remember, here's another point, that people aren't going to consider any change unless and until they are convinced that there is a problem that truly needs to be addressed. And that's where all the information you heard from Dr. MacDonald and others about what's happening, how folks are dying when they're getting out of prison without treatment. There's a problem out there, and it affects lives, and that's why we're doing this. Again, all levels of the organization. What helped us in Rhode Island was our governor was a champion and was totally supportive and gave us the money to do this. If you have a supportive governor and high-level officials or sheriff, that's going to make the job so much easier of making this program effective, because people look to the top to see. If there's not support from the top, if your director, if your assistant director of rehab services, if your medical director is really not on board with this, folks aren't going to follow. You really need to do that and get folks involved. How do you do that? You have to educate them, right? We've gone through a lot of education here. We learned we had to spend a lot of time educating our staff using a lot of techniques so that we were able to create a successful program. And we had our bumps in the road. And in this afternoon's workshop, we're going to talk about all the mistakes we made. So I've heard a lot of accolades for the Rhode Island program from people, and I really appreciate that. But please don't be fooled into believing that we woke up one day, we did this, and we had all these successes. We suffered, we struggled, we battled. There's a lot of blood, sweat, and tears. Dr. Clark lost a lot of nights' sleep, I know. It's a rough road, but it's a road and it's a fight, it's a battle worth fighting. So get your armor on as you go back home and prepare for the attacks, because they're going to come. What are they going to look like? Generally, attacks are going to fall into 4 major categories. And people will employ either one or all 4 of these tacks. And I'm going to talk a little bit quickly about each of them and see if you recognize these attacks with MAT if you're doing it, or any other new initiative that you start. The first attack strategy is confusion. In this attack, the person attempts to sink a good idea by muddling the discussions with irrelevant facts, convoluted logic, or so many alternatives that it's impossible to have a clear and intelligent dialogue that builds buy-in. Some individuals can be astonishingly clever at drawing you into a discussion that is so complex that a reasonable person simply gives up and walks away. If this strategy is allowed to succeed, others in the room will begin to wonder, does this really make sense? You'll hear things like, and we heard this, you're replacing one drug with another. You're keeping people addicted, and you're calling it treatment. What we really need around here to address the opioid problem is blah, 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 and all these other off-the-wall, non-evidence-based ideas. The second attack strategy that you'll see, and I think you'll be familiar with this, death by delay. So this attack makes what seems like logical suggestions, but which, if you accept them, will make the project go on and on and on with so many meetings, other discussions, that the momentum is lost and another idea, not nearly as good, gains foothold. You've heard this one, let's create a task force ploy is used. It's a powerful strategy, right? Because it's easy to deploy. Momentum can be slow to the point that it can never be regained. I've heard this. Let's call every single jail and prison in the country and talk to them to see what they're doing. Let's form a committee and review this for a few months so we really understand it. Then let's get Brown University and write a comprehensive paper that can be reviewed by university professors, and then we could get their feedback, and then, and ultimately the process is so drawn out that the idea dies. So you got to guard against that. Fear-mongering is the third. This attack raises anxiety so much that you can't have a thoughtful examination of the proposal. People begin to be filled with ideas with frightening risks. Pushing people's anxiety buttons is very manipulative, but it's an effective tactic. And the anxieties don't necessarily disappear even if the person is faced with an analytically sound rebuttal. If only humans were logical creatures, wouldn't life be so much easier? This wouldn't be a problem. But we're not, and we're far from it. And this can be contagious. So we heard things like, drug use will get out of control if we do this. Everyone's going to be put on the program, and all our inmates are going to be high all the time. We're going to lose control of the prison. It's going to become more dangerous for all of us to come to work every day, and on and on. And then the fourth and last major attack strategy, sometimes when all else fails, is ridicule and character assassination. This attack throws verbal bullets, not at the idea, but at the person or people presenting the ideas behind the idea. They try to make you look silly. Strong buy-in is rarely achieved if the audience feels uneasy with those presenting a proposal. So when the strategy works, there could be collateral damage. Not only is a good idea wounded and a person's reputation unfairly tarnished, but all the additional sensible ideas from that person might then have less credibility, at least until the memory of the attack fades. Things like, and I'm going to be honest, I'm going to be blunt, you're a jerk. You're so naive, you don't get it. You're an inmate lover. You have no concept of how a prison needs to operate. It's going to happen. So clever attacks based on one or all four of these strategies can be very powerful. Again, we saw all of them in our department when we introduced MAT, and if we're being honest, even today we see some of them, but to a much smaller extent. So now that you're familiar with the four broad major categories of attack, let me just show you briefly, talk briefly about how to address them. Again, every situation is unique, but there are some basic general rules to follow. The first one, anticipate and prepare for attacks in advance. We'll talk about some specific attacks in the workshop this afternoon, but they're inevitably coming your way, and they're very, very predictable. So don't be surprised and don't try to wing it. Even if you know the facts thoroughly about MAT and why it's a good idea and how it could work, and even if you think your ideas are bulletproof, and even if you expect the audience to be friendly, because there's going to be someone in that room that's going to get it going, and it's going to go south really quick if you're not prepared. Don't be afraid of distractors. There's going to be distractors. But handled correctly, they can actually help you. And sometimes the biggest opponents can become your best advocate. If you were here yesterday, you heard from Lieutenant Bray. Lieutenant Bray was one of those people who thought this was a horrible idea, would never work, why are we doing it? But with training, education, experience, she became a real believer. And not only is she a believer, but now she's part of the team, and she's able to talk with other security members, people who were on the fence, and get more buy-in from them. So sometimes hearing your distractors, talking to them, working it through, they can become your biggest allies. I remember my first year of social work school, one of the things I learned in doing community organizing, when you sit with a group, you look for the loudest person, the biggest jerk in the room that just gives you a hard time, and have lunch with them. and try to bring them on board onto your side. Because they're passionate about the topic, but they have some misunderstanding sometimes. And you can do that. And those people, oftentimes, you'll say, oh my God, we just didn't get along, we were like water and oil, and ultimately they're your best advocate. That could happen with MAT also. So expect naysayers and those that are going to point out how horrible your proposal is and why it'll never work. Expect resistance, challenges, as well as ill-informed, unfair, illogical, and sneaky comments. But don't scheme to keep these potential opponents, even the sneakiest ones, out of the discussion, as much as you would like to ignore them or use your best mixed martial arts move on them. Can't do that. Let them in, let them shoot at you, even encourage them to shoot at you. Expose the project to criticism, because if you don't do that, they're going to do it behind your back anyhow. So prepare for it. Conflict engages people. I'm sorry, I didn't see my little card. How many minutes do I have? I have 1 minute. Okay. Boy. So I'm going to move on. So these are the kind of attacks you're going to see. I'll let you read them to yourself. And these, again, we've had them all. We talked about them all. There's a lot of personalities you're going to meet. Pompous, meaty, hide the agenda, avoid us risky, all is well. If I had more time, I'd talk about each of these people, but they're going to be there. Be prepared, expect it, because you're going to have to deal with them. So as I conclude, you know, we made mistakes, we fell, but we never failed, and you're never going to fail, because what you're going to do is you're going to succeed or you're going to learn. And either one of those is okay. It's okay to learn and move on. And just finally, again, in our workshop this afternoon, I'm going to be with Dr. Brent Gibson from NCCHC, and we're going to talk about the Rhode Island experience, and we're going to be very candid about the things we did well, and more so about the things we didn't do very well, so that you can learn from our mistakes. Thank you for your attention.
Technical assistance is available to support the evidence-based prevention, treatment, and recovery of opioid use disorder. To request technical assistance, visit opioidresponsenetwork.org.